Hello everyone. Today we will be presenting on schizoaffective disorder. My name is Krislyn Martinez.
And I'm Sade Olarewaju.
And Sade will be talking to us about the general description of schizoaffective disorder.
Schizoaffective disorder is a lifelong mental illness that is characterized by symptoms of schizophrenia and a major mood disorder. There are two categories within the diagnosis: schizoaffective bipolar type and schizoaffective depressive type. The symptoms include hallucinations, delusions, and distorted thinking, in addition to symptoms commonly found with depression or mania. Around 0.3% to 0.8% of the population are diagnosed with this disorder, and schizoaffective disorder is diagnosed about a third of the time as often as schizophrenia. Onset of schizoaffective disorder typically occurs in early adulthood and is often diagnosed late due to the symptoms overlapping with other mental disorders such as schizophrenia and bipolar disorder. Schizoaffective disorder requires lifelong treatment, and individuals living with this illness have a higher risk for hospitalization, suicide, and substance abuse. Schizoaffective disorder also creates cognitive deficits that have a major impact on one's social and occupational functioning. This makes it harder to develop and maintain relationships, maintain employment, and have meaningful roles in the community.
Before discussing treatment options, I would like to touch on some of the critiques that the diagnosis and diagnostic criteria schizoaffective disorder receives, as it will help provide a lens on the information we review during the presentation. While there is some research specifically on schizoaffective disorder, much of the available research discusses schizoaffective disorder on a schizophrenic spectrum, which could include schizoaffective, schizophrenia, delusional disorders, and even brief psychotic disorders. Critiques around the diagnostic criteria arise due to poor reliability between clinicians diagnosing the disorder. Meaning, while someone could diagnose someone with schizoaffective disorder, it would not be uncommon for the same individual to receive a different diagnosis, such as schizophrenia or a mood disorder with psychotic features, from a different clinician. Much of the poor reliability comes from clinicians either over or underemphasizing aspects of the psychotic symptoms in comparison to the affective symptoms in individual experiences. The blurring of lines could impact one's treatment options or the guidelines a clinician will utilize. Currently, due to diagnostic ambiguity, there are no strict or set guidelines in treating schizoaffective disorder. We will be looking into the treatment options. I will focus on the pharmacotherapy, and Sade will look at the psychotherapy treatment options. While there are no guidelines to treating schizoaffective disorder, the typical and initial method is often based on the treatment of schizophrenia. As you can see in the diagram, the medication approach looks similar when addressing both disorders. The way the medications are selected and may differ are through what symptoms appear to be more present in the individual. As you see antipsychotic in the middle, there are two classes of antipsychotics, typical and atypical. Typical antipsychotics have displayed more side effects that impair working memory, processing speed, and motor skills. Atypical antipsychotics have shown to be more successful in addressing affective disorders such as major depressive disorder and bipolar disorder. Haloperidol is an atypical antipsychotic and is currently the only certified drug to treat schizoaffective disorder, and this may be offered monotherapeutically or in conjunction with mood stabilizers and/or antidepressants. This medication regimen may also be beneficial to individuals for long-term treatment in order to mitigate the possibility of relapse. If an individual is treatment resistant, meaning that they do not respond to the typical methods of treatment for schizoaffective disorder, clozapine is often considered because of its effectiveness in treating depressive-related symptoms, manic behaviors, and stabilization of mood. Clozapine has demonstrated some effectiveness in individuals with treatment-resistant schizophrenia and bipolar disorder. Therefore, it appeared a logical decision to examine the efficacy of clozapine treatment in individuals with schizoaffective disorder. Clinicians may augment clozapine with other medications, such as risperidone, which is another atypical antipsychotic. When considering individuals who experience severe symptoms and have demonstrated difficulty managing their medication, Long-acting injectable antipsychotics, known as LAIs, may be a way to encourage long-term treatment adherence. Some examples of these LAIs include paliperidone palmitate, olanzapine pamoate, and risperidone microspheres. While this method is less common, it may be particularly beneficial for a diagnosis like schizoaffective due to the commonality of poor treatment adherence when utilizing typical oral medication treatments. This poor medication management is highly correlated with psychotic symptoms, substance use, and frequent hospitalizations. One study found that though 75% of patients diagnosed with schizoaffective disorder were being treated with antipsychotics, less than 50% of the patients were adherent to the medication treatment. I know this chart has a lot of information, but I circled the numbers that I wanted to highlight and discuss. As you can see, schizophrenia is on the left-hand side and schizoaffective is on the right. The numbers circled are the percentage of individuals being prescribed varying numbers of medications. I thought this chart was interesting as it displays how someone with schizoaffective disorder is less likely than someone with schizophrenia to be prescribed just one medication, usually the antipsychotic. When looking at the rates of the combination of two medications between the disorders, the rates are similar and always include an antipsychotic. However, when looking at the combination of 3 and even 4 classes of medications, individuals with schizoaffective are more likely to have these higher number combinations of medications compared to individuals with schizophrenia.
In order to address low treatment adherence, psychoeducation is one intervention that has started to be included in the treatment of schizoaffective disorder. This table from a study on the benefits of psychoeducation illustrates how this intervention is utilized. The beginning of treatment provides a basic understanding of the diagnosis, including symptomology, stigma, and coping strategies. The middle of treatment educates individuals about their medication treatment plan, possible side effects, and how to cope with said side effects. The final part of treatment would include role-playing exercises to help ensure that individuals are able to utilize the skills outside of a treatment setting. The outcomes of providing psychoeducation on the diagnosis are improved attitudes towards medications and a better understanding of the necessity of medications. This leads to a reduction in noncompliance with medications, decreases in rehospitalizations, and a shorter length of stay at the hospital. Increased self-care, communication with health providers, and self-esteem and confidence in their ability to cope are other benefits of psychoeducation. Another relatively new psychotherapy option for schizoaffective disorder is EMDR and prolonged exposure therapy. These therapies were initially created to treat PTSD. PTSD and schizoaffective disorder have similar traits like increased arousal, which presents as hypervigilance, poor sleep or anger, and negative cognitions, such as distrust in others. As a result, researchers have explored the benefits of adapting EMDR and prolonged exposure to the treatment of schizoaffective disorder. EMDR utilizes eye movements to help process distressing memories. The therapist moves their finger back and forth in front of their patient's eyes or utilizes alternating tones while the patient recalls distressing memories and the accompanying thoughts and emotions. Similarly, prolonged exposure also involves processing traumatic memories by having patients recall in great detail the distressing event and discussing arising emotions during sessions with the therapist. The patient is also instructed to gradually expose themselves to stimuli, such as people, places, sounds, and smells that are associated with the distressing event. The use of EMDR and prolonged exposure in the treatment of schizoaffective disorder results in a decrease in the severity of paranoid thoughts and depression that is maintained 6 months post-treatment. As you can see on the graphs, prolonged exposure had a more significant impact than EMDR on decreasing paranoid thinking and depression. This can be attributed to the fact that prolonged exposure requires participants to complete homework assignments, which is not a part of EMDR therapy. EMDR and prolonged exposure did not make any notable differences on auditory verbal hallucinations or social functioning. The third psychotherapy treatment approach is contextual cognitive behavioral therapy, otherwise known as CCBT. This intervention views the different modalities of CBT, such as mindfulness, compassion-focused therapy, or acceptance and commitment therapy, as a context in which to enact behavioral change. CBT emphasizes function or context of psychological events like thoughts, memories, or emotions over their frequency, content, or veracity. By focusing on the context of psychological events, individuals have an increased awareness of and an ability to handle distressing situations. This happens when individuals are flexible, accepting, and embracing of all experiences and their own internal reactions, which allow them to engage in actions that align with their values. Specifically within the different contexts, mindfulness interventions led to improvement regarding anxiety, depressive symptoms, insight, psychotic symptoms, and functioning. Acceptance-based interventions helped improve distress related to symptoms, social interference, depressive symptoms, psychotic symptoms, and global functioning, also quality of life and insight. Compassion-focused therapy improved depressive symptoms, social marginalization, and observed clinical improvement. And DBT reduced depressive symptoms, fear of emotional states, and improved control over emotional states. Cognitive remediation is another type of psychotherapy that is being used with individuals diagnosed with schizoaffective disorders. Research has shown that the impairments in working memory, attention, processing speed, visual and verbal learning, and deficits in reasoning, planning, abstract thinking, and problem solving associated with the diagnosis have a serious impact on psychosocial functioning. Cognitive remediation targets key cognitive functions to help an individual do more complex cognitive tasks. The table here illustrates some of the improvements that occurred during a study on the benefits of cognitive remediation therapy. Processing speeds improved by 21% after cognitive remediation, attention improved by almost 15%, working memory by 33%, and reasoning and problem solving by almost 12%. Overall, cognitive functioning improved by 48.91%. Two specific cognitive remediation therapies include integrated neurocognitive therapy, known as INT, and recovery-oriented cognitive therapy, known as CTR. INT entails using strategies that provide cognitive remediation via compensatory and reparative interventions. Compensatory interventions bypass deficits and reinforce existing cognitive skills and environmental resources, which promote the adaptation to the context in which the patient lives and the adaptation of their behavior to the specific situations. Restorative interventions attempt to fix deficits by practice exercises and drills. INT is composed of 4 modules. Module A takes into account the processing speed, attention, and perception of emotions. Module B concerns verbal and visual learning and memory, social perception, and theory of mind. Module C is about reasoning, problem solving, and social schemes. And Module D trains working memory and the ability to attribute appropriate meanings. CTR is a cognitive remediation intervention that incorporates the recovery model. The focus of treatment is to neutralize negative beliefs and attitudes while activating each individual's undiscovered positive attitudes to promote enduring adaptive living in the community. Therapists put emphasis on the engagement and rapport building process during treatment. This allows them to work collaboratively with their clients to identify meaningful roles and aspirations for the future, in addition to developing personal and social efficacy. This approach can be beneficial when working with individuals who may be more withdrawn due to their symptoms and are resistant to psychiatric treatment. The expected outcomes of utilizing INT in combination with medication are a decrease in negative symptoms and an improvement in overall cognitive impairment. CTR has demonstrated outcomes of having lasting effects long after therapy concludes and improvements in motivation and daily functioning. Next, we will be exploring clinical considerations, including diversity issues and environmental factors. Minorities, specifically African Americans and Latinos, are misdiagnosed with either schizophrenia or schizoaffective disorder at rates higher than non-Latino whites. When considering the proportion of individuals with the diagnosis, whites actually appear to be underdiagnosed. Clinicians have been observed to overemphasize psychotic symptoms and minimize affective symptoms. Specifically for African Americans, their symptoms may be viewed as more disruptive and socially deviant. African Americans are also less likely to report positive symptoms, but are more likely to be diagnosed with schizophrenia or schizoaffective disorder. A lack of understanding of cultural differences may lead to behavioral hospitalizations, which has been linked to a higher chance of being diagnosed with a psychotic disorder. As a result, individuals that are misdiagnosed are provided with ineffective treatment plans. This can lead to consequences such as frustration, treatment dropout, delayed treatment response, poorer health outcomes, and increased suicide. Researchers have also found that non-Hispanic Blacks had lower rates of antidepressant and mood stabilizer use compared to Hispanics and non-Hispanic whites. This can be attributed to socioeconomic factors such as having fewer resources and less thorough evaluations that can lead to a poorer understanding of an individual's diagnosis. Minority patients were less likely to be offered CBT, family therapy, and care plans in comparison to white patients. Minorities are also more likely to enter treatment through coercive methods, which may include involuntary hospitalization, involuntary medications, or court-mandated treatment.
I will be discussing some of the factors that contribute to the diagnosis of schizoaffective disorder. The exact cause of schizoaffective disorder is unknown, but it is likely a combination of factors that would contribute to the development of the disorder. I have listed some of the factors below. David Rosenthal's diathesis stress model could be a way to combine some of the factors listed and explain them. The diathesis stress model is a highly cited theory when discussing the onset of schizophrenia, but can provide insight into the diagnosis of schizoaffective disorder as well. The interaction of predisposed genetic vulnerabilities, or the diathesis, and the stressors one experiences in their daily life could lead to the development of a serious disorder like schizoaffective. As previously mentioned, treatment compliance among individuals with schizoaffective disorder is often inconsistent due to the nature of their symptoms, especially when experiencing manic-related symptoms. Substance use is unfortunately very prevalent among individuals with diagnoses like schizoaffective disorder. These individuals may be at a higher risk of substance use due to a combination of factors such as low socioeconomic status, delayed cognitive abilities, and/or poor social functioning. Substance use has a bidirectional impact as it could affect the severity and intensity of the symptom experienced by someone, and in turn, the intensity of the symptoms, along with poor self-control, could lead someone to turn to substance use in an attempt to mitigate the severity of the symptoms. The interaction between sleep and the management of schizoaffective disorder is highly related, and unfortunately, many individuals with this diagnosis also meet criteria for insomnia. Conditions like insomnia can exacerbate the positive symptoms involved with schizoaffective disorder or indicate a red flag that management of symptoms is declining. Short sleeping patterns and poor sleep quality can severely and negatively impact anyone, but when considering its effect on an individual with schizoaffective disorder, the results can be even more severe and negatively impact their treatment. In addition, individuals who report early life adversities, such as abuse or unstable homes, and negative relationships with their family are less likely to have the support needed to access treatment and resources consistently, which is imperative in positive treatment outcomes for schizoaffective disorder. Lastly, internalized stigma can negatively affect an individual's mental health and delay or impede their willingness to seek treatment. As you can see in the diagram on the right, the barrier that stigma has on individuals adds an unwanted and unnecessary barrier to their already intense symptoms of being diagnosed with schizoaffective disorder. Stigma can lead to severe impairments of psychosocial functioning in daily life. Internalized stigma impacts treatment by causing patients to be avoidant in the forms of secrecy, high dropout rates, and difficulties with self-regulation. Thank you for taking the time to listen to our presentation on schizoaffective disorder. Bye.
Bye.